Hi, Gibson, Steve Nicholls coming to you from ESC 2023. Steve, I'm one of the 20% of the population out there who has an elevated LP little a. We walk around, we don't know we have it. Very, very, very few people are tested, yet it is an independent risk factor for heart disease. And you are presenting here a late breaker on a new oral medicine, a small inhibiting RNA molecule against Lp(a) that would turn down its production. It could be of tremendous benefit. Talk to us a little bit about what you're doing and what you found.
Well, I think this is an exciting space. We've seen a number of new therapies go into clinical development in recent years. They're all RNA targeted therapies. They all essentially switch off production of ApoA in the liver, but they're all injectable. And we'll see what happens to them in clinical trials. Here at the ESC, we're going to present phase 1 data for the first oral small molecule inhibitor of Lp(a) that's gone into clinical development. It's an agent called Muvalaplin. Muvalaplin works in a slightly different way. It's essentially what we call an Lp(a) disruptor. And what it does is it essentially prevents the binding of ApoA to ApoB.
Hmm.
And we know that if they don't form that complex, the ApoA pretty quickly kind of disappears. It has no functional consequence, and you don't form a standard Lp(a) kind of particle.
And just to
So what
kind of educate our audience, I mean, you have LDL, and then you get this ApoA attached to it, and that constitutes Lp(a), right?
it does, and we think that that's a particularly atherogenic particle,
Hmm.
but we think it potentially does a few other things. We think it's prothrombotic. We think it may play a role in calcific aortic valve disease.
Hmm.
And as you said, 20% of the population have high Lp(a)s. You and I see those people in our clinics, and these people are frustrated because, at least to date, there are no therapies in the clinic that they can use. And so we desperately need Lp(a) lowering therapies. I think the idea of having an oral option is good for patients, particularly those patients who won't want to take injections. And so this is an exciting space.
So exercise doesn't get it down, weight loss doesn't get it down, statins don't get it down. In fact, maybe make it a little higher. PCSK9 inhibition variably diminishes it, didn't reduce it for me. What did you find?
So small study, phase 1, predominantly around tolerability, is well tolerated. But what we are reassured at is that we see dose-dependent lowering of Lp(a) by up to 65%. We think that that's a pretty good place to start. If you kind of think about the degree of Lp(a) lowering that we're probably going to need to see significant reductions in MACE events in large trials, we're thinking that it's probably going to be at least 50%, if not more. So we think that this is a good start.
Any safety side effects to be worried about?
No, pretty well tolerated. The other thing we looked at is that we know that Lp(a) has a homology with plasminogen. So there is a theoretical concern that when you target Lp(a), you may disrupt antithrombotic activities. We measured a range of plasminogen and plasminogen related biomarkers and didn't see significant changes in any of them, which I think is reassuring as well.
Very reassuring. We have a lot of work to do to educate the population about Lp(a). I'm working at that very hard as someone who has an elevated Lp(a). Good to see this on the horizon. Steve, thanks for joining us, and thanks to all of you for joining us here from ESC 2023.